To you all the members. We really appreciate you for participating in this forum. I also want to congratulate Dr. Rao, Dr. Rao Kishan. He's one of the best mentors I've ever met in online. I really follow White Army in YouTube and Instagram, even in WhatsApp and Telegram. And they normally share clinical cases. I've learned and benefited a lot from them, and I don't take it for granted. Once again, I want to say thank you.
I really appreciate that. Okay, really appreciate. So, shall we start the presentation?
Yes.
Okay.
So I've collected these patients 3 weeks ago in Mubende Regional Referral Hospital. The name of the patient is Tomohire Agnes. She's 18 years old and she's female. She lives in Mubende district and she belongs to Munyoro tribe, which reside in the central part of Uganda. She's a student. She belongs to Protestant faith, and the case is not referral. She's in high school now, senior 2, and she's not married. Yes, the next of kin is Zawadi, and the date of admission is the 1st of October 2022, but I've clocked 2 days after the admission. So she presented with a pain in the right side of the abdomen for 4 days. So she was well until 4 days ago, until 4 days prior to admission, when she developed pain in the paraumbilical region. The pain was gradual, dull in nature, intermittent, and moderate. The pain later migrated to the right iliac fossa, and it was aggravated by coughing and sudden movement, and it was relieved by moving and taking an analgesic. When I asked her to rate the pain, she rated the pain during the attack 7 in the scale of 0 to 10. The next, the pain was associated with nausea, vomiting, anorexia, especially after eating, and also low-grade fever. She also reported episodes of diarrhea. However, there was no history of constipation, abdominal distension, and dysphagia. She reported no history of difficulty in maturation, urgency, and frequency. However, she reported her last menstrual period was 3 days prior to the admission, and there were no period bleeding. The patient also had intense body fatigue, and there was no history of abdominal trauma. The review of other systems, starting with CNS, she only had mild headaches, but other symptoms were unremarkable. No history of dizziness, blood vision, seizures, and loss of consciousness. On respiratory system, there were no history of cough, hemoptysis, dyspnea, and chest pain. CNS, sorry, next. Yes, cardiovascular system, there were no history of palpitation, dyspnea, orthopnea, and PND. Musculoskeletal system, no history of joint pain, swelling, or limitation of the movement of any joint. Past medical history, this was her index admission. Sorry.
Sorry, Abdul, there was some voice disturbances from your side. Now it got corrected. Can you start from past surgical history?
Yes, past surgical history. She reported no history of previous operations, no blood transfusion or trauma. Family history. She is the second born of the 3 children. All are normal. Sorry, all they were born by normal birth. And the first of the 23, sorry, the first born is 23 years old, and the last born is 8 years old. All the children are well. Her mother is healthy, but the father is diabetic, and he had amputations done on his leg for diabetes. She's a peasant farmer, and there is no history of DM, hypertension, asthma, epilepsy in the family. Social history. The patient lived in semi-permanent house with her children, with her siblings, sorry. That's a mistake there. With her siblings. She grows local food in the garden, and they dispose the rubbish in nearby banana plantation. No history of alcohol consumption or smoking. Summary. Mohiro, 18 years old, female, who presented with low abdominal pain in the right side of the abdomen for 4 days, which was associated with anorexia, nausea, and vomiting, and no history of diarrhea and constipation.
Good. Very good presentation. You are so clear and very confident while presenting. Now, at the end of history, you know the story of the patient now. So, Dr. Abdul, what do you think maybe the probable cause for her pain abdomen?
In this case, I think it is appendicitis.
Okay. So, we keep appendicitis in mind, and also don't be narrowed down to the appendicitis. Keep all the possibilities in mind. Okay, keep all the possibilities, what all can happen in the pain in the right side of the abdomen. Keeping that in mind, we will discuss elaboratively one by one. Whatever we presented, let's know the importance of each thing. Okay, so you say it's a case of appendicitis. So, what is the relationship between age and appendicitis? Can you say?
Yes, I think appendicitis is common in middle age or young adults.
Very good.
Because that is the time where the lymphoid tissues grow, and lymphoid dysplasia is one of the causes.
Yeah, correct. What about the gender predisposition?
Yes, it's common in girls than boys. But I don't know.
It's more common in males, but yeah, it can occur in females as well, especially during the reproductive age group in the pregnancy and all. It can be more common. What about the race? Race has got any particular predisposition?
Yeah, I read that it's common in white and Asians.
Exactly. Okay, this is more common because of this westernized diet, maybe. Okay, so it's more common in the whites and in the Asians and all. So we should keep that in mind. So and then why next thing? Pain in the right side of the patient has come to you. You just assume that you are sitting in the OPD or in your clinic. A young lady has come to you with pain in the right side of the abdomen for 4 days. So what is your thought process is like? What are all you think the possibilities? Just with this one line, a 18-year-old young lady has come with pain in the right side of the abdomen for 4 days.
Yes, it can be due to gynecological causes.
Very
also,
good. Very good.
Ectopic pregnancy, ruptured ectopic pregnancy, one of them.
Very good.
Ovulation also.
Correct.
Yes.
Then what else?
Then it can be also like urinary cases, urinary system, like ureteric colic.
Very good. Ureteric colic. Very good. Ureteric calculus.
Calculus, yeah. Then it can be pelvic.
What are the structures? See, Abdul, it's very easy to answer. You need not have to think anything, or you need not have to mug up anything. Okay. If you know the basic anatomy, okay, what are the structures comes in around in the right iliac fossa? If you know that, you can tell. Okay. So what are the structures we get in the right iliac fossa? Ovary.
Yeah, ovarian torsion now.
Okay.
Is one of the cause, yeah. Then we have the ureters.
Ureters, very good. Then that's what you
Then
call
we have-
calculus. Distal ureter
Yes.
calculus possibilities. What else?
Yes. We have the ileum and it's the
Yeah.
ileocecal junction.
So what can happen with that?
Bowel obstruction and interception, especially in children.
Inflammation, pain. Pain is mainly by inflammation. Okay, so
Yeah.
inflammation
So
of the
Crohn's
ileum, which
disease, Crohn's disease.
ileitis, regional ileitis.
Yeah.
Then what is the inflammation of cecum is called cecum typhlitis. It's called typhlitis. Okay, and there are so many lymph nodes there. Lymph nodes. Okay, these intestines are covered by mesentery. So these mesenteric lymph nodes can get inflamed, and it can cause
Mesenteric adenitis or lymphadenitis.
lymphadenitis, very common. And what is the near that structure can be there? What is that? In the children, especially in the distal part of the ileum, there could be very good. What is the name of the diverticulum?
Meckel's diverticulum.
Very good, Meckel's diverticulum. So there are 4 or 5 things which cannot be easily distinguished or cannot be ruled out so easily. When a young lady like this comes with right iliac or right lower abdomen pain, okay, that is one is like you said appendicitis. It could be. Second thing, it could be right distal ureteric colic, salpingo-oophouritis. Okay, that's of the oophouritis and ovarian torsion. Okay, and it could be typhlitis or ileitis. All those things. What are the structures in and around the right iliac fossa? We should come to our mind. Okay, why this duration is important? 4 days duration. Why is this important?
Because it's an acute disease.
Sorry.
It's an acute disease.
Yeah. So only we will think of some acute conditions. So malignancies, all this, other TB, all other inflammatory, all those things are ruled out here itself. So some acute condition of the abdomen is happening there. If you think of appendicitis itself, duration is important in that, in any way. You think this is a case of appendicitis. We assume that this is a case of appendicitis. So duration of pain is important in any way.
Yes.
How?
Because appendicitis, like the more it stays, the more it can get ruptured, and the pain will no longer be in the right iliac fossa. Now it's going to cause generalized peritonitis.
Very good. And more than that, anything before getting ruptured, and ruptured is unlikely in this age group.
It is sorry.
Rupture is unlikely in this age group. What is other common complication of appendicitis?
Abscess formation.
No, they'll come with severe fever and all. Only pain is there, and it's 5 days old. Since 5 days or 4 days. So what more common thing you think of? What's the most common complication of appendicitis?
Bowel obstruction.
No, how the body tries to overcome this inflammation? What happens?
Yes, fever.
Yeah, fever is one of the manifestation. How that appendicular mass,
Okay.
Whenever there is an inflammation in the body tries to conceal that by that momentum goes there and tries to pack it, and nearby water structures they all come around and form a mass. Correct? They occur between 3 to 5 days after an acute episode of appendicitis. So any case like this, complaints of appendicitis comes after 4 or 5 days, we should be careful about appendicular mass formation. Okay, for that also duration is important. Usually the patients come on the first day itself. They'll have severe pain, and then they'll come in the first day itself. If they come like this after 4 or 5 days, we should be careful about having appendicular mass formation. Okay, which can further lead to, like you said, appendicular abscess. Okay, all those things. Fine. So can you describe the type of pain in appendicitis, the typical classical pain?
The pain initially starts around the umbilicus,
Very good.
umbilical pain. then it later shifts to the right iliac fossa.
Why is it so? What's the mechanism? Why there is appendicular pain is around the umbilicus?
Because initially the pain is visceral.
Very good.
Because of the distended appendix is going to
Very
press,
good.
or it's going to affect the visceral peritoneum, and the pain is visceral pain.
Very good. Then
And
later on, what
it's
happens?
It's poorly localized, and it's dull in nature. But later on, when the parietal peritoneum is involved, it becomes now sharp and well localized in the right iliac fossa.
And it's more of a somatic pain, correct? It's a localized somatic pain. Excellent, excellent understanding. So this is a classical example for migratory type of pain. We have many types of like radiating type of pain, referred pains, and in this appendicitis, we have one classical migratory type of pain. Initially, they will have pain around the umbilicus, which slowly gets migrated towards right iliac fossa, correct? And they will have a pain, the tenderness in one point. What's the pain point called?
McBurney's point.
McBurney's point. Okay. So, what other complaints she had other than pain?
She also the pain now was
vomiting.
Vomiting.
Vomiting. Okay. Now she had vomiting. Why there will be vomiting in case of appendicitis?
I think bowel irritation and also
very good.
Spasm.
Great answer. So because of reflex pylorospasm, okay, there will be vomiting of the food contents. So then there can they can develop this low-grade fever, like you mentioned. So this is classical history. First they will have pain, then go on to develop vomiting, and then they'll have this low-grade fever. What is this triad is called?
Murphy's triad.
Murphy's triad. Okay, Murphy's triad. Classically, there's sequence also very important. Okay, first they'll have pain, then vomiting, and then they'll have this thing about fever. Now, why you have written about this history of constipation, other things, distension, dysphagia, and all? Why? Or diarrhea?
Bowel obstruction is also one of the differentials.
Good. Can they have appendicitis? Patients can have diarrhea?
Yes.
How?
I think also, I don't know the mechanism, but they can also present with diarrhea.
The pelvic appendix, if the appendix is toward the pelvis, that can irritate the colon and the rectum. Okay, that can cause diarrhea. Okay, can they have? Why you are told it's difficulty in micturition, urgency, frequency? Why is that so? You wanted to rule out UTI or something?
UTI also, because pyelonephritis is one of the differentials.
Can appendicitis can cause all these features?
Sorry?
Can appendicitis cause these symptoms like difficulty?
Yes.
How?
If it's pelvic appendix, as you just said now,
it can inflamed appendix can irritate the bladder.
Can irritate the bladder, yes.
Okay, that can cause a similar this thing. Okay, so intense body fatigue, okay, and malaise, all these maybe features of fever again, and no history of abdominal trauma. So you want to rule out the traumatic causes, correct, of the abdominal pain. Good. So now the central nervous system, almost all respiratory system, all those are no significant findings. The musculoskeletal system. Past medical history, you mentioned about having peptic ulcer disease. Has this got any relevance between with the present condition?
Yes, of course. If it's perforated PUD, it can also present with the right iliac fossa pain.
Excellent. How? Tell me.
I think the content can now collect in the right iliac region.
Through paracolic gutter from the duodenal ulcer, which will perforate, and its contents will migrate through the right paracolic gutter and will collect in the right iliac fossa. Okay, so then there will be this peritonitis features, and which will mimic appendicitis. This is called one syndrome. This is commonly asked in your entrance exams, PG entrance exams. It's called Valentino Syndrome. You know, a king, Valentine, was killed because of this misdiagnosis. They thought it's appendicitis, but he actually had this perforation of the duodenum, which left untreated, and he died because of that. Okay, it's called Valentino Syndrome. You should know that. And steroids, she's taking dexamethasone tablet. Okay, can this cause appendicitis?
Yeah,
Anyway,
they have,
just think,
yeah,
logic.
it has effect on appendicitis because it's an immunosuppressive drug. Therefore,
Very
it can
good.
suppress
Very
the
good, man. You're a genius. Dr. Abdul, you're a genius. I'll tell you. So yes, it's an immunosuppressant. So anyway, normal bacterial flora can multiply, okay, and they can cause contamination and inflammation. Good. And she had no history of drug or food allergy, no history of chronic illness. Why in an 18-year-old girl? Why did you ask the history of this diabetes mellitus, hypertension, TB, and all?
To start with, diabetic, I think, especially in young adults, they commonly have DM type 1, and if it's DKA now, it can also present with abdominal symptoms like abdominal pain.
Very good. Type 1 diabetes mellitus is more prone to get DKA. Very good. So why hypertension? Is it so common in young?
No, not really.
If yes, what is the cause? Most common cause?
Like contraceptives.
Hypertension, contraceptives.
It's more of secondary hypertension.
Sorry. No, what is I'm asking simple question. What are the causes for hypertension in young, like 18-year, 20-year?
Pheochromocytoma.
Very good, wonderful. Pheochromocytoma. Anything else? Any anatomical? Can you think of in that right lumbar region? Near that pheochromocytoma only.
Kidney.
What happens to kidney? Renal,
like
artery,
artery stenosis.
Stenosis. Very good, very good. So these are some of the causes to have hypertension in the young. Okay, so you wanted, and TB, as you know, in developing countries like ours and yours, we have to rule out TB first. Okay, this is a great mimicker, Dr. Abdul. Tuberculosis can mimic anything and everything. Okay, got it? So in our and your countries, we have to rule out in every patient tuberculosis first. Okay, so we will rule out that. And past surgical history, why this is important? How any surgery is related to appendicitis?
Yes, if there is past surgery done on her, she can have bowel obstruction, maybe secondary to adhesions, and then that one now will present with abdominal pain. Okay,
so you see that gridiron scar, okay, an examination, and she say last 1 year back I had appendicectomy. In the past history, past surgical history, lady will give the history that 1 year back I had appendicectomy. Now I having again similar pain there. Is it possible?
Yes, after 1 year.
Yeah, after 1 year.
Yes.
Or maybe after 6 months, whenever you want. You that's your choice. You take it whenever you want it. After 1 month or 6 months or 1 year, it again she has similar pain there. Is it possible?
Yes, I really don't know that one.
Especially she will tell that I had underwent a laparoscopic appendicectomy earlier, and now she comes with.
Can it cause bowel obstruction?
No. No. Stump appendicitis. Some people, what they leave a big stump of appendix behind. Okay. That stump again can cause inflammation. That's called stump appendicitis. You understood?
Okay.
So what if this lady has presented with left iliac fossa pain? Young lady, 17, 18-year-old lady, presented with left iliac fossa pain and vomiting and low-grade fever.
Yeah, it can be diverticulosis.
Okay. Next.
Yes, also. Yes, I can only think of that one. And maybe bowel obstruction also.
Enterocolitis, okay. But
enterocolitis, okay.
No, I'm telling you, this is appendicitis. I'm telling you,
Okay, okay.
I'm your
yeah.
boss. I'm your boss there. Okay, in your Kampala University, I'm the boss who is doing the rounds. You are a casualty. You are my casualty intern. You call me up and say in the night, sir, there is a case. A 16-year-old girl has come with left iliac fossa pain and having vomiting and low-grade fever, sir. So then immediately I say, Dr. Abdul, it's a appendicitis. Then you say, hey, sir, what is this? Appendix is on the right side. How can she have appendicitis on the left side?
Yeah, it can be also anatomical variation.
Yeah, very good. That we should keep. See, I'm giving just an orientation. Okay. I'm not checking your knowledge or I'm not giving you any extra knowledge here. Yeah, I'm just giving an orientation. Just being a budding medico, your thinking should be very broad. Okay. So even left side, what is that called? Situs inversus. You know, some young in congenital malformation like situs invertus. All the liver will be on the left side and the heart will be on the right side, like that. All the organs will be. All another lady has got pain in the right hypochondrium. I say it's appendicitis.
Yes, if maybe she's pregnant.
No, not pregnant. Yeah, good. Your thinking is right. Your thinking is right. But say I say she's not pregnant. You just answered it. It's again anatomical variation. What is that? It's a subhepatic appendix. Okay, that's because of mal rotation. See, you gut, embryology you have studied. All the gut rotates from the left to right. Then so from subhepatic to descends down to the right iliac fossa. See, if it doesn't happen, then it's called mal rotation. Okay, so in mal rotation, usually appendix is found in the right hypochondrium. So again, possibilities. So all those things, anatomical variations, we should know and we should keep this in mind. Okay, so family history, is it appendicitis familial?
Yes.
Could be, okay. Some 20-25% of the case could be familial, especially those who are having a long appendix with a loose mesentery and all, they can undergo this. Okay, good. So social history, it's more common in which socioeconomic group? Appendicitis.
In the low socioeconomic.
Not really. It's in midland affluent because of the food, high fatty food, high fatty diet. High fatty diet. Okay. So what's the most common cause for appendicitis?
E. coli.
Very good. So this fatty food, okay, they can form more of E. coli. And what's the most common organism?
Is it E. coli?
Very good. Very good. E. coli is the most common. And the question can be tricky. Dr. Abdul, they can ask you, if they really want to dig you, which is the most common anaerobic bacteria, they'll ask you. Sorry, it's the most common gram positive or aerobic bacteria. Which is the most common aerobic? Which is the most common anaerobic?
Clostridium.
Aerobic is E. coli, anaerobic is bacteroids. Bacteroids fragilis. Okay. So these are the things. See, I'm just giving orientation. All this comes up in your PG entrance examinations, all those things. Okay. So socioeconomic history, it's more common in higher socioeconomic class because of the diet. So summary wise, you're okay. A young lady presented with right lower abdominal pain for 4 days, associated with anorexia, nausea, vomiting, and no history of diarrhea and constipation. Very good. So we think that most probably GI system is involved. Most probably appendicitis. Okay, as per the history, and we want to also rule out other gynecological problems like ovarian torsion or salpingo-oophorytis and mesenteric lymphitis, other things. So let's proceed for examination.
Yes, a young aged girl, lady, who was in supine position in her bed in a fair general condition. She is conscious and alert, febrile to touch, with normal hair color. She didn't have pallor of the conjunctiva, no jaundice of the sclera, and no cyanosis, and no finger clubbing. She had no edema, no lymphadenopathy, but had mild dehydration. Vital signs, the pulse rate was 80 beats per minute.
Mhm.
Respiratory rate was 19 breaths per minute. Temperature 37.4 degrees Celsius. Blood pressure was 115 by 80 US millimeters per mercury. And then SpO2 was 95%. Systemic examination per abdomen. The abdomen was flat. It was moving with respiration. The umbilicus was inverted, and there were no therapeutic scars. On auscultation, the bowel sounds were reduced. Normal tympanic sound on percussion. On light palpation, there was marked rebound tenderness and muscle guarding in the right lower quadrant. On deep palpation, there was no organomegaly, masses were identified. However, on deep palpation, the left iliac fossa, the Rovsing sign was positive, and also psoas sign was positive.
Very good.
The respiratory system, there was no signs of respiratory distress, scars, or local swelling. The trachea was centrally placed. The chest expansion was symmetrical. On percussion, there was a normal, it was normal bilaterally, and the chest was clear on auscultation bilaterally. Cardiovascular system, the blood pressure was 115 by 80 millimeters per mercury. The pulse was normal, fullness, and regular, synchronous. The GBP was not raised, and there was no chest markings. The heart sound S1 and S2 were heard, and there were no murmurs or any other added sounds. CNS, the cranial nerves were intact, no meningeal irritation, no meningeal sign. The muscle tone and muscle bulk and muscle power were all normal. The rectal examination, I have not done that one. Impression is acute appendicitis.
Okay. So we will rule out, or we'll come back to the examination, and we'll let's learn the importance of each thing. Okay. So she's not very toxic. I mean to say, you can, by the appearance only, initial appearance, by general condition only, you can make out that it's not very toxic condition like appendicular abscess or some peritonitis, all those things. Okay. So she's conscious, febrile on touch. Okay. And other vital parameters are all okay. So why is measuring pulse is important here?
Yes, because of that stressful condition like inflammation. It can lead to tachycardia.
Okay, they'll have because of the fever and inflammation, they can have sinus tachycardia. And what about the blood pressure?
Yes, also, yes, it can, that septic condition can also cause hypotension.
Hypotension, okay, very good. So it can lead to hypotension. And temperature, we usually measure in degree Fahrenheit, okay? So there is nothing to measure 37.4 degree Celsius, okay? So keep that in mind. And saturation is 95%, okay, fine. So per abdomen, you have done a very detailed examination. I'm really happy. And the abdomen was flat, okay? It's not distended, no collection ruled out. And it was moving correspondingly with respiration. Especially, you should check all the regions or all the quadrants, whether they're moving correspondingly with respiration or not. Okay. If you see any limitation of movement anywhere in the abdomen, that means that that area is affected. Got it?
Okay.
And umbilicus inverted, it's normal. And on auscultation, bowel sounds were reduced. Why?
Yes, I think there was no peristalsis.
Why? Is it a bowel obstruction are we dealing with?
No.
Then?
Because the distended appendix can also press on the bowel.
What is that condition called? Inflamed appendix touching on the bowels and causing them not to act properly. What's it called?
I don't.
No proper peristalsis happening. Paralytic.
Ileus.
Yes.
Paralytic ileus.
Yes. Okay. Paralytic ileus. That's why bowel sounds may be reduced. Okay. That can also cause distension of the abdomen a bit. Clear? And normal resonant on percussion all over the abdomen. And on light palpation, there was a marked rebound tenderness. How do you elicit this rebound tenderness, my dear?
Yeah. When you palpate on the right iliac fossa, the patient only feels the pain when you remove the hand from the point of palpation.
Yeah. Okay. There's this, any sign you know? This name of the sign?
Plumbar sign.
Very good. Very good. There is nothing like Dr. Abdul Majid doesn't know. Okay. Very good. Blumberg sign. Okay. So have you asked the patient to cough and elicited the pain?
Not really.
That's one of the another signs. Okay. Ask the patient to cough, and that time she will feel pain in that McBurney's point. That's called Dunphy's sign. Dunphy's. D-U-N-P-H-Y. Just like Murphy, it's Dunphy. What is this guarding? There was marked muscle guarding on right lower quadrant you mentioned.
Guarding is voluntary movement of voluntary muscle contraction when to avoid pain.
Okay. So what is the difference between guarding and rigidity?
Guarding is voluntary, and rigidity is involuntary muscle spasm because of inflammation. So, and that's correct. Guarding is voluntary, whereas rigidity is involuntary. Okay. Guarding is voluntary contraction of muscles, whereas in rigidity is involuntary spasm of the muscles because of the peritonitis. And guarding is localized. It's localized in one place, whereas rigidity is generalized. Okay. You got it? Difference. Okay. And on deep palpation, no organomegaly and masses were identified. Yeah, this is important. See, on deep palpation, you are mainly looking for appendicular mass. Whether this appendicitis has formed any mass around. It's very well localized mass you can get of the ileum, colon, mesentery, and the inflamed appendix. Everything will form a mass, very well localized mass in the right iliac fossa that you are looking for. Okay. And what is this Rosing sign? Rosing sign is pain in the right iliac fossa after you palpate the left iliac fossa.
Okay. Why? What's the mechanism?
I think the gut contains gas, so when you palpate the left iliac fossa, so you're exerting a lot of pressure, backward pressure to the right iliac.
Right. Correct. Just to modify, when you press on the left side, all the gut will be pushed towards the right, and when they touch the inflamed appendix, that will pain will be exacerbated. You got it? With normal colon, when it touches the inflamed appendix, then that can elicit a pain. That's called Rosing sign. And the psoas sign. Okay, fine. Next, respiratory system is all normal. On cardiovascular system, that's okay. Central and why this rectal examination is important here? What you're looking for?
If it's a pelvic appendix, then you can better appreciate when you do rectal examination because there's a tenderness in the posterior region of the rectum.
Not posterior, but right lateral. Right lateral, but part of the rectum, you can feel the tenderness. Okay, patient will feel the tenderness. Okay, when doing rectal examination. So finally, you clinically you think it's a case of acute appendicitis by the history and the classical on examination. She has tenderness in the. What is pointing sign? What is pointing sign? You know.
Pointing sign is the tenderness upon touching the McBurney's point.
Yeah, when you ask the patient to show where is the maximum tenderness, patient with her index finger will directly touch the McBurney's point, point of maximum tenderness. It's called pointing sign. Okay, so now this is a very crucial step, Dr. Abdul. you have so many differential diagnoses in mind. So how do we rule out one by one clinically? Without the help of any investigation, we want to rule out one by one. So first you say ovarian cyst torsion.
Yeah, ovarian cyst torsion. I think the nature of the pain is different here because I said this is migratory pain, but the other one is localized.
Okay.
Ovarian.
Very good. Salpingo-oophorytis.
Also use the same clinical use.
Yeah. Ectopic ruptured ectopic pregnancy.
Now that one history can help me.
What is the history?
Because she had a bleeding 3 days prior to.
Excellent, man. You are really genius. I'll tell you, Dr. Abdul, you are a real genius. Okay. All our Indian students should learn from you. There's a lot to learn from you. Okay. What about the perforated peptic ulcer disease?
Yeah, also history.
Of?
Yeah, and then
they'll have give you a history of previous pain in the epigastric region.
Epigastric region, yes. Yeah. And also whether the pain becomes worse with the eating.
So why do you include this rectus sheath hematoma here?
Sorry?
Why did you include rectus sheath hematoma here? Is there any history of trauma in this patient?
No.
Then there's chances of spontaneous hematoma possible?
Not really.
See, no. Pancreatitis also, again, see, differential should be such that they are very close to your diagnosis. That mimic appendicitis, one is could be ileitis, regional ileitis. Then it could be
Crohn's disease also.
Yeah, Crohn's disease. Then
ureteric coli.
Yeah, distal ureteric calculi. See, again, distal ureteric calculi you can rule out by history. How?
Because there are no associated symptoms of urinary symptoms.
Okay, that's the one thing. Then anything else? What type of pain they will have in ureteric calculus?
Yeah, of course, it's colic type of pain.
Yeah, colic type of pain. And anything else? Will it be continuously there for 4-5 days like this?
No.
It will be intermittent pain they'll have. Okay. Initially, they'll have very severe pain, and after some time, that's because of spasm mainly. After some time, spasm will be relieved and they'll be relieved of the pain. So they'll have typical colic type of and intermittent type of pain. So that's also ruled out. Okay. So what's more common here possibilities is one is salpingo-oophorytis. Okay. And in young ladies, this Yersinia colitis. Yersinia, there's a colitis, ileitis, or typhlitis. All these are very common. Okay. So these are mimic, almost same thing. You can't rule out just by history or examination. So only these are the differential diagnoses. You can't give pancreatitis as differential diagnosis in this case, or you can't give a rupture like a hematoma differential diagnosis here. You're clear? Got my point? Just for the sake of differentials, you can't say some 4-5 differentials. All those conditions should mimic exactly. In this index case, what are the features are there? Like you said, in this there are features are pain, vomiting, and there's a low-grade fever. These features should be there in all the cases. In the ureteric calculus, why there will be fever? Unless there is a UTI. Okay. So you can't hematoma. Will there be any fever or vomiting? Hello. Can you hear me?
Yes. No. Yeah, I can hear you.
Yeah. So that's what I was telling. So have differentials which are very close, which we can't clinically differentiate. Only such differentials you should keep. Okay. So now the next question is your chief will ask you, okay, Dr. Abdul, you have diagnosed the case of acute appendicitis. Now, how do you manage this case? How do you manage this case?
Yes,
you are the entire sole intern in the entire casualty, and no seniors are available, no chief is available in the night. So what do you do next?
Of course, I will resuscitate the patients. giving IV fluids, analgesics.
Very good.
If he's hypoglycemic, I will give dextrose. Then broad spectrum or empiric antibiotics until culture is done. Yes.
So first thing, what we have to do is confirm the diagnosis. Correct? Yeah, you have done the empirical management, but that's not enough. We have to confirm the diagnosis first. So what do you do to confirm the diagnosis? Before treating, we have to confirm our diagnosis. We have made a clinical diagnosis of acute appendicitis. Next thing is we have to confirm, because if it's a ruptured or like torsion ovarian, it's a grave emergency. We can't wait. Okay. So how do we confirm our diagnosis now?
Investigations.
You like?
Ultrasound.
Yes, good. That's the first investigation you should say. The investigation which will immediately help to diagnose the condition. That is ultrasound of the abdomen. Okay, that will give you. If it's appendicitis, what will be the feature of USG?
Thickened wall of the appendix becomes more than 6 millimeters.
Okay, that's a,
then also periappendicular thickening.
Periappendicular collection. Okay.
Collection. Then
how do you describe? How do you describe an appendix? Yeah, fecalith can be seen. How do you exactly describe an appendix with appendicitis? It will be blind-ended loop. Blind-ended loop, which is aperistaltic. There is no peristalsis in that loop, and there is non-compressible. Usually, any bowel or anything could be compressible or putting pressure over that. But in this blind loop is non-compressible because of the pent-up secretions or collection inside. Okay, and like you said, the width, the AP diameter will be more than 6 mm. Okay, anteroposterior diameter will be more than 6 millimeter, and the thickness, wall thickness, will be more than 2 millimeter. And there could be associated fecalith or inflammatory collection all around. These are all the features of appendicitis on ultrasonography. Okay, so many a times it's not possible to identify appendicitis in ultrasonography. Why? What is the drawback?
If there is abscess,
if there is a gas, okay, so bowels are distended with gas. Okay, this is very poorly. This ultrasound cannot penetrate to the gaseous medium, air medium. Okay, so the appendix cannot be well visualized. So that cannot localize the appendicitis. So then we have to go for CT abdomen. So what is the most common location of the appendix?
The anatomical location?
Yeah.
Right iliac fossa.
Yeah. In right iliac fossa, with reference to the ileum, what is the most common location?
Tinea coli, the point of converge, where they converge the three.
Yeah, that's right. There's a tip like this. It can go anywhere. No, the tip of the appendix can be anywhere. Yes. It will be pelvic. You told sometimes it will be pelvic, sometimes it will be pre-ileal and post-ileal. So where's the most common site or location?
Yes.
That again makes it very difficult to find.
Retrocecal.
Yeah, someone already put in the chat section as well. What is that? Mr. Enyang Boni is telling Abdul Hassan is a genius for sure. Yes, I also agree with him. Yes, retrocecal. Retrocecal is the most common. So behind the cecum is like this. Behind that, again, when you do ultrasonography from the above, there is cecum, which is a distant cecum is there, which is filled with air, which again masks appendix. So it cannot be well visualized. Okay, retrocecal is 70% of the times we find appendix behind the cecum. That's called retrocecal. Second most common is the pelvic. Okay, 20% of the times we find it in the pelvis. Clear? Okay, that is about. Then what other investigation you want to get done to confirm your diagnosis?
Of course, I will also do routine investigations like CBC because I need to see leukocytosis.
Then
I will do HCG, Peter HCG, to exclude ectopic pregnancy.
Very good.
Urinalysis,
Very good.
to exclude UTIs. Then
So you know
CT scan is
any
also done.
in severity, how to assess the severity of appendix or confirm any scoring system, you know?
Alvarado,
Modified Alvarado scoring. In that, the favorite question of the examiners is which, it's out of 10 points, okay, 10 points, okay. Which two criteria has got 2 points? That's a tricky way to ask.
yes, tender in the right iliac fossa and leukocytosis.
Very good, very good. Okay, these two have got 2 points each, and the rest of the things have 1 point each. If it's more than 9 or 10, then it's confirmatory of appendicitis. Correct? Good, good. So once appendicitis is confirmed, then what is the next plan of action?
Conduct appendicectomy surgery.
Okay, so surgical. So yeah, you can manage it. Medical management can be done. Like already mentioned, there can be antibiotics, which broad spectrum antibiotics, which cover all the aerobic, anaerobic, gram positive, gram negative bacteria, which will cover. That should be given. Then analgesics or antipyretics should be given. IV fluid should be given. Okay, well, medical you can manage. Okay, and second thing is the best is if you medically manage, what will happen? Tell me, what's the drawback of medical management?
Failure, of course. Okay.
Sorry.
Yeah, it's not guaranteed.
Yeah, why it's not guaranteed? Yeah, once the inflammation will subside, definitely. There is some voice disturbance from the side.
Yes, hello, I can hear you now.
Yeah. What's the cause for appendicitis? See, if you give the antibiotics, definitely the inflammation will come down. Okay,
Yes,
but
yes.
what is the root cause for that inflammation? What's causing? What's obstructing the appendical lumen, which causes all the bacterial translocation, everything, and causing inflammation? What is the root cause? You told no in the beginning. What's the most common cause of appendicitis? Fecolith. If you give these antibiotics, IV fluids, all those things, this fecolith will not go out. That will be it will be there blocking the appendix. Correct. So that will after some times again it will recur. This appendicitis will recur after some time. So the definitive treatment would be to go for a appendicectomy along with you take out the appendix along with that fecolith. Clear? Clear? So what are the types of appendicectomy you know, and how do you do that?
I'm not conversant with the surgical aspect of it.
Sorry, I couldn't hear you.
I'm not well conversant with the surgical aspect of it.
Okay. I'll tell you, it's either an open appendicectomy or laparoscopic appendicectomy can be done. In a conventional open method, we put what is the incision name? Commonly put McBurney's incision, or also called MacArthur's gridiron incision. What is the point? 2/3 from the umbilicus and 1/3 from the ASIS.
Yes,
Superior iliac spine.
Yes.
A line is drawn like that, and perpendicular to that, at a 2/3, 1/3 junction, we put a incision, and then other layers are separated. The muscle is split, okay, and then peritoneum is opened, and then we look for the appendix. How do you identify the appendix?
Using Tinea coli.
Where the base of the trace the Tinea coli at its base, we can find the appendix. Okay, one more clue that it's a case of appendicitis. As soon as we open the peritoneum, we'll come to know that this appendicitis. Even before we seeing the appendix, we'll come to know that this appendicitis. How?
Sorry.
As soon as we open the peritoneum,
yes,
okay, we can be sure that this is a case of appendicitis only. Even before seeing the appendix, how? What will be there? Coming and covering around.
Abscess.
Momentum will come. Greater momentum that will be covered the appendix, right? So as soon as we open the peritoneum, we can see the momentum. Then we separate the omentum, and then we find the inflamed appendix. Okay, that will be attached with the mesentery, mesoappendix. Okay, then we separate this in the meso. What is the significance of this mesoappendix?
It contains appendicular artery.
Yeah, it's a branch of
ileocecal.
Yeah.
Or
Okay. Ileocolic.
Yeah, ileocolic
artery. So this mesoappendix contains this appendicular artery. So we have to separate this mesoappendix from the appendix and ligate the artery. So appendix is separated now. Okay, it's naked. So we ligate at the base of the appendix. We ligate. We using a suture. We ligate and we take off this appendix. Clear? Okay. That's appendicectomy, and they close the layers. And what are the complications of appendicectomy?
Surgical site infection.
Oh, very good. This is most common. Very good. Because already inflammation, already infected. So there are high chances that surgical wound site will get infected. Very good. See, this is how you should answer. Any student for that matter, you should answer like Abdul. The common ones are always answered at the first, and the rare ones, the late ones, are answered second or third. This is a good way of answering. Abdul, please continue.
I think I'm done. My PowerPoints are done.
I couldn't hear you.
Yes, I think I'm done. Yes. Hello?
Yeah.
Yeah, I said I think I'm done. My PowerPoints are done.
Yeah, PowerPoints are done. Yeah. Okay. So those are the complications of appendicitis. After appendicectomy, bleeding can occur. If you slip that appendicular artery, okay, if it ruptured, that can cause torrential bleeding. Okay, and you can injure the near adjacent organs. If there is appendicular mass has formed and you try to remove the appendix from that can cause one of the dreaded complication of that surgery is fecal fistula. It can cause fecal fistulas. Okay, see, all these are the complications. And one more thing, you should keep that in mind. If any extremes of ages, patients of extreme ages, like in the children or very elderly, comes to you with appendicitis, you should operate immediately, because there are high chances of perforation. Okay, why? Because appendicular artery is an end artery. Okay, so there are high chance of necrosis and they burst open. The perforation is very common. So you have to operate as early as possible, because in the children, the omentum is not well developed. Immunity also not well developed, and the omentum is also not well developed. So they won't go cover and contain the inflammation. So the high chances that this will get perforated. In the aged also, this omentum will be very atrophied. It's atrophied. So again, it cannot move and cover it up. Okay. And second thing is, in aged, abdominal wall is very lax. So they cannot really localize the pain. So you have a high amount of suspicion of appendicitis in elderly also. So these are some of the conditions where you need to take timely intervention to save the possible complications and the patient's life.